Good morning, everyone. We will now begin with the first of the 6 WHO-led sessions under RAISE. This session is titled AI and Scalability Lessons from Population Level Deployments and Pathways for Responsible Adoption. This session brings together AI innovators, scientists, and implementation leaders who have successfully deployed AI solutions at population scale within real-world health systems across India and beyond. May I now request our distinguished speakers for this session to kindly join us on the stage. First, may I request Dr. Karthik Adapa, Regional Advisor, Digital Health and AI, WHO-SEARO, to please join us on the stage. Next, I call upon Dr. Geetha Manjunath, Founder, CEO and CTO, NIRAMAI Health Analytix. May I now request Dr. Anand Sivaraman, CEO and co-founder of Remidio, to join us. Next, I invite Ms. Veena Moktali, co-founder and CEO of Periwinkle Technologies. I now request Dr. Shantanu Pathak, co-founder of Care Mother, to please join us. And also joining us virtually, we have Dr. Alpan Raval, Chief Scientist, AI/ML, Wadhwani AI. Thank you all for joining us today. To begin with the session, I now invite Dr. Karthik Adapa to kindly deliver the keynote address.
Good morning again. What I'll try and do is, in the next 10 minutes, try and give a quick level overview of what is the current state of scaling of AI in LMIC health systems. To start with, essentially when we think about AI, very often we kind of limit ourselves to just a very specific group of people. But at World Health Organization, and purely as a scientist, and I'm also speaking for all the innovators here, so I think what's going to be important for us is to bring all of us into this conversation and make AI work for people. And for that reason, you need the emphasis on scaling. And that's one of the reasons why we have the first session essentially on scaling of AI. Now, before we go into AI, there is a lot of lessons that we can essentially learn, because digital health has, over the past 2 decades, reached scalability. Now, in India, we have telemedicine at about 300,000 calls per day. In Zanzibar, you have about 1.6 million people essentially connecting a platform that connects about 100% of the community health workers. And you have in Rwanda, a universal digital health platform that again registers about 2.9 million citizens of the country. But it's not that digital health is actually evolved in scale very quickly. We've had tremendous challenges as well. Now, what you see here is this common problem of pilotitis that existed in digital health for about 2 decades, and there's the same problem that you see in AI as well. This is a map of Uganda, and every red dot that you see here is an innovation, a pilot that happened that really did not scale. Now, this has been the learnings over 2 decades. And when you see digital health systems, before we move into AI, this is the variety of digital health platforms that exist in Indonesia. And you can see the large number of fragmentation of digital health systems. And this is not unique just for Indonesia. It could be true for a large number of LMIC countries. What it really does is it really puts the health worker at trouble, where typically even in Madhya Pradesh, studies suggest there are about 80 different digital health applications that a healthcare worker needs to remember. Now, let's take it a larger continental level. And the reason why I'm going to Africa is because Africa essentially seen over the past decade or so, more than 800 odd applications which have been funded by a variety of donors, and a fraction of them have truly scaled. So scaling has been a problem in digital health, and we've been able to try and solve that to an extent, but not majorly as well. And another big problem that you see here is the fragmentation in the resourcing. So alignment of resources also has been a big problem. Now, with that, once with digital health coming in, digital health applications coming in, one major thing that has happened is data became available. But healthcare, compared to all other sectors, has been one of the most difficult sectors to digitize. So the amount of data that's available globally, healthcare typically generates just about 5% of it. So first, digitalization has been challenging. 2, when you generate data, it's just about a fraction of what the global world has. And that data, in terms of both data quality, data integrity, and data fidelity, has been a problem. But that does not really stop us from using AI. And what you can see here is across the various areas of population health, individual health, health systems, and across the care continuum, we've seen a variety of use cases of using AI. Now, with all of this, what it becomes very important is where can you scale AI? And how do you really scale AI? And what really are the big gaps? The first big gap that you see here is how do you move AI from the lab to the clinic? So very often, the most major AI innovations that you see, which really grab the eyeballs of the world, are essentially in research. The number of applications that really move from a lab to the clinic are far and few. Then when you move from clinic, initially most of them are proof of concepts. But then when they get deployed, adopted in clinical environment is another big gap that you see. But what is the vision that you really want? If you really want AI to be used at the population level, that's again a much bigger problem. So this is, of course, a translational gap. And how do you really move from gap 1, gap 2, and really go at the population level? And for that, I'm trying to highlight just about 3 broad things. One is on the complexity of the interventions, the science of interventions, and the methodological rigor that we need, and how classic RCTs may not really work. Then I'll try and focus a little bit of the lessons that we've learned on digital health, on the importance of this understanding the socio-technical system, the user-centered design and clinical simulation, and then move a little bit on the implementation science, because we'll have other experts who will lead us into what does it really take to scale in LMIC setup. Now, the big problem in digital health, and typically which applies to AI as well, is when you think about development of a drug, there's a very clinical, a drug development process is phased, it's well known, it's undergone a lot of rigor in how do you really develop drugs. But when it comes to digital health and typically AI, the big gaps that you have are right from innovation discovery till you get into regulation and post-market safety monitoring. There are huge gaps in validating and evaluating, and these become much more difficult in LMICs where the health systems are highly variable. Now, the first challenge in a LMIC setup is when you look into the global clinical evidence that comes out of AI, what really stood out for us is the variety of randomized controlled trials, which is typically the gold standard in clinical medicine. You see that there isn't a single study in India for sure. In Southeast Asia, it's just Bangladesh which has a single study. So using the classic RCT model, typically we are not generating evidence in clinical AI in LMIC setups. What you see, most of these studies, essentially 60% of the studies are either in the US or in Europe or in China. So in LMIC setups, and you can see a large amount of blank except for Rwanda and Malawi in Africa, and couple of studies, most of the LMICs are not able to use randomized controlled trials for generating evidence in health AI, and the reasons are fairly easier to understand, both in terms of cost, in terms of duration, in terms of eligibility. So what is really evolved is the traditional randomized controlled trials, because of the factors that most of you would understand, are becoming very challenging. And so we're moving towards more of a real-world evidence, real-world data to validate. And so therefore, there has been this emergence of these pragmatic RCTs. And some of our innovators will talk to the need for these pragmatic RCTs and more of real-world evidence. And that's typically where AI will need to bring in this methodological rigor. Now, how do you really balance between integrating these classic RCTs into pragmatic RCTs? How do you build them into real-world evidence and then generate evidence that can really work at scale? And that's been the big challenge. So there has been this integrating evidence synthesis and coming out with new causal mechanisms. And this is one such recent work that's come from the US FDA, where how do you really integrate classic RCTs, pragmatic RCTs, build in real-world evidence, which the regulators can then start using to validate for these AI tools. Now, 2-3 broad summaries that are coming about is, one, you will probably have to transport RCTs to broader populations using real-world data. Second is, we need hybrid control trials that combine both randomized and external controls. We probably have to link these short-term RCTs with the long-term real-world evidence if you're really thinking about safety monitoring, because most AI machine learning tools, because of model drift and shift, will need to be monitored even after the deployment. If that is the more on the methodological side, the second major part is on the health systems readiness. Now, this is something which I'm showing from the United States, which show that health systems, even in the US, are essentially struggling as we build these AI tools, generate a lot of evidence in clinical environment. If you want to deploy them at scale, health systems typically are not even ready, even in a high-income country like the United States. So what really stands out is, even a health system like Stanford, and the reason why I'm picking out Stanford specifically is because Stanford was by far the first health system that actually had a chief AI scientist only with the single job of bringing evidence-based clinical tools and deploy them at scale in a clinical environment in Stanford. And they started this about 6 years back. And Stanford as a health system is also struggling to really deploy them in clinical environment and adopt them at scale. Amongst that, of course, you see on the top is what is Mayo. Mayo typically stands out much ahead of the rest of the curve. And we were trying to understand what is it that Mayo is doing really well. And if you really look into Mayo, which is essentially the AI factory, if you look into large healthcare systems in the US, what it really does well is they've been thinking clearly from an impact evaluation, data life cycles, model building, production. But what is very, very clear is if that was the traditional model, the Mayo Clinic platform goes much more deeper than that. And I can spend a lot more time on this, but what I just want to highlight is that just because of the interdisciplinary research and the ability that Mayo has traditionally been able to build as the one university which has a department of AI, which clearly brings in all these experts together, and the reason why they've been able to deliver a large number of them in clinical environment is an important case study by itself. But the other major thing that I want to highlight from health systems readiness is now essentially on the thinking that clinical AI is not just a product. And so you'll have to think not just about the technical challenges, but more as a socio-technical system. So very often when you talk to AI machine learning scientists, they would typically stay in this phase of what are all the technical and clinical interface challenges. But what is going to be more important is, if we really want to deploy at scale, understand the clinical context challenges, and then much more bigger are going to be the wider context challenges. So in here, even in the clinical context, something that we can really do well, and that's where the knowledge that we have over the past 2 decades, essentially from human factors, can really help us, is on trying to first focus at least on these 4 things. One is, how do you really work on poor usability, improve the user experience of AI machine learning tools, and how do you ensure that you fit them within existing workflows? And the third thing is the fact that very often when AI comes in, the essential learning today is when human AI integration happens, it is not always that the human AI is going to be better than human alone or AI alone. So there's a lot of emerging evidence in this middle piece itself. Now, when you look into the globally, what internationally studies show, you have a lot of guidance that is coming on ethical principles, data privacy, technical validation, risk management, but very little absence of guidelines on what does it take to create the business solutions, the UI design, what are the implementation strategies, how do you do a return on investment on an AI machine learning solution. So most of the guidelines you can see, the dark blue, are essentially ones which are much more primordial in my opinion, But if it is in the later stage where the guidelines are essentially not coming, and even if they come, they are all largely in the high income settings. So the usability and usefulness, user experience of the tools, I don't need to highlight, but one major study from the US FDA clearly shows that most of the ones that are approved by the US FDA are not being really used primarily because of poor usability. So therefore, it becomes very important that as AI machine learning tools get developed, how do you really integrate them into workflows? Not just clinical workflows, but public health system workflows. And this is this very interesting study which highlighted the case that I'm talking about, where AI and human beings, when they integrate, when they interact with each other, very often we think that we use an AI tool and we're already going to perform better. But this study very clearly highlights that very often human AI is not really synergistic. It could also be antagonistic. And so we really need to understand where in clinical workflows human AI integration is not synergistic, could also be antagonistic, and it could probably be not better than human alone or AI alone. And so the emphasis of how do you really deploy them into clinical and larger public health system workflows is going to be very important. Now, another piece of major learning that we've had in digital health is on the importance of clinical simulation. So as we use user-centered design, use co-design models, what is going to be very important is to embed clinical simulation, ensure that these AI machine learning tools also not just use a user-centered design process, but actually simulate them using qualitative exploration of user needs, but also use scenario-based usability and safety testing. So very often, we just build a tool in the lab, you take it to the clinical environment, and we think that clinicians will start enjoying these tools. And very often it does not happen like that, right? And therefore, the methods of clinical simulation have been used in high-income countries for about 2 decades. And there's a lot of evidence on how clinical simulation methods would work at scale in clinical adoption. Now, with all of that, the other major thing that has emerged is how do you bring all of these pieces together? And that's where implementation science comes in. Now, there have been a large number of frameworks that talked about how do you really do an end-to-end clinical implementation of AI. And one framework that really stood out is from Australia, which is called the Salient Framework. And what it really does is it highlights the need for developing these human AI interface solutions. And so across all the stages, right from defining the problem statement to a retrospective study, a silent study, piloting it, and a large trial where the emphasis is still RCTs in this framework, you would see that there is a need to incorporate them into clinical workflows. But these frameworks, and I'm sure our innovators will speak to this, that these are frameworks that really need a lot more resources to implement. Now, this is another such phased model framework which the American Medical Informatics Association uses to really drive the gaps between clinic to the population level. And this has been one framework which has been widely used. In fact, one such framework started way back in 2020, which uses typically the drug manufacturing methodology and has applied this to AI. And what we're learning is these frameworks typically don't work in LMIC setup. And so this is something which one of our experts will speak to, and this is work from Punjab. When we try to implement a breast cancer screening tool at scale, what really shows is the re-engineering of the public health systems that you really need. So the AI tool, the AI thermal device, which Dr. Geetha is going to talk about, is essentially a very small component of an entire workflow from a public health system. So the essential standpoint that I want to place before you is, if you really want AI to work at scale, it's not seeing it just as a single element, but to see it as a big public health system. You'll need the public health systems to be strengthened. We will need clinical workflows. We will need these tools to be integrated into clinical workflows. And so if you truly want AI to work at scale, the 3 things that I want to highlight is, 1, the methodological rigor. and the changes that we need to make from real world evidence, the importance of doing more pragmatic RCTs or maybe much more lighter methodologies, more hybrid trials. Second is the importance of using human factors, usability, and clinical simulation. And third is how do we build implementation science frameworks that are more specific, that are more suitable to LMIC countries. And so, what I just want to highlight are some of those key challenges that exist. Well, I'm highlighting the challenges, but what we're hoping to hear from people who've actually done this. So, the 4 experts that you're going to hear after this are people who've actually done this at scale. And so, what I want to just give colleagues to think about is I'm not here to propound for one specific tool or a product. It is about what does it really take to implement at scale. And so some of the speakers that are going to come here are ones who've done it at scale. And so we're essentially trying to think about and understand what is the science of scaling for LMICs. And I think this is more a question from my end rather than an answer. Thank you all so much.
Thank you, Dr. Karthik. I now request Dr. Alpan Raval, Chief Scientist, AI/ML, Wadhwani AI. He will be presenting virtually.
Thank you for having me as part of this discussion, and I apologize for not being there in person. What I'd like to talk about today in the next 10 minutes is about AI at scale in public health specifically, because most of our work is in the public health space. In fact, all of our health work is in the public health space. And the lessons that we've learned from scaled AI deployments in public health. In a nutshell, what might work for scaled AI in public health and what certainly doesn't work. So as I will argue, I think we are still in the very early phase of scaled AI in health in general and in public health in particular. And so there are ongoing lessons that are going on, and it's not completely clear yet as to what works and what doesn't. But some of the things are turning out to be clear. So I think most people in this room know why we should use AI in public health. There's a number of advantages. You can do improved disease screening and diagnostics at scale. You can extract insights out of unstructured health data, EMRs, and so on. There's the potential to do automated disease surveillance at population scale. You can do objective and accurate future risk estimation for disease, and you can do this at a personalized level, at a community level, and so on. And of course, AI with the language capabilities that we have now, the language and the speech capabilities, it has the ability to circumvent language barriers, health taboos, and superstitions. So I'll just briefly describe what we do. So Wadhwani AI is an independent non-profit tech institute. We do have a strong program component as well. And our mission is really to benefit underserved communities in India using AI technologies. And by underserved, I mainly mean rural communities as well as the urban poor. We work closely with government bodies and other partners for data, for deployment, and essentially to achieve scale. And our usual modus operandi is to work backwards from the ground to use the constraints on the ground to drive the technology. We work in healthcare, agriculture, and education. Healthcare really is our dominant domain of work. So I'd like to backtrack a bit. When we talk about applied AI at scale, not just in healthcare, but in general, we should look a bit at the history of applied AI. A lot of people, when they talk about AI, talk about the history of AI in general, and that's fairly well known. But applications have a somewhat checkered history. If you look at applications, AI applications that have stuck, there's really not too many applications like that. So for example, pre-1990, mostly applications were one-off applications like in games, playing games like chess and Go and so on. Some pattern recognition applications. In the 1990s, AI began to be systematically used in biology and in finance. A lot of the hedge funds were using AI. In biology, a lot of the impetus came from the availability of DNA and protein sequences, and it sort of grew until the Human Genome Project, and then the Human Genome Project spurred a lot of AI applications in biology. And this continues till today. AlphaFold, for example, is a sort of culmination of this entire effort. From the 2000s onwards, AI has really found its groove in applications that are tailored to internet platforms, and that's where AI found scale, right? And things like recommendations and search, these are the two big applied AI problems where AI has made a significant difference, and it's been deployed at massive scale. For example, in results of web searches, in e-commerce recommendations, online ads, social media personalization, and so on. And this scale is really massive. We haven't seen anything like that type of scale in other domains. So today we have technologies like visual recognition, voice-based assistants, chatbots, translation assistants, and all of these leverage internet scale data. So internet is the big platform that's enabled AI to a large extent, enabled applied AI. And the reason I brought this up is because through the internet, you got a series of repeated, highly frequent, scaled AI deployments over 2 decades. And these deployments have revealed where AI works, what doesn't work, where you need complex algorithms, where you need simple algorithms, why responsible AI is important. And so a lot of these successes and limitations of methodologies came to the fore because of 2 decades of these deployments. So I just want you to keep this in the back of your mind as we go through the public health applications. So relatively speaking, applied AI in public health is still very nascent. We are just beginning to hit scale. And in fact, for various reasons that I don't have time to get into, India is a major place to do this. We have the population, we have the diversity, we have the need for public health that's unique, right? So one can go into all these factors in detail, but this is the place to do AI in public health at scale. And in fact, I would argue that public health has advantages for a technology like AI. First of all, in public health, you care more about screening than diagnosis. And therefore, the AI does not have to be super accurate. You can take a basic AI model and still deploy it usefully. The second point is that public health applications automatically give rise to scale because pretty much everyone needs to be screened or prevented from disease. And this level of scale leads to powerful lessons for other types of AI applications. The last point is public health applications give agency to the human expert. They always naturally have human in the loop. Now, what I would say is that the type of scale needed, if you just go back and compare to the internet platforms, the type of scale that's needed to learn the majority of lessons about AI in real-world settings, in public health settings especially, is yet to be achieved. And so this is a journey that we should keep in mind. This has just begun. I think this is a very opportune time to take stock of what we are doing here. And this will either turn out to be a huge tsunami or it will turn out to be a dud. We don't know how things will develop. So I'm going to very briefly go through the work that we at Wadhwani are doing in TB, for example. TB has the advantage of the 𝐏𝐶 platform, which is sort of in a sense, the internet for TB. And we've been able to successfully deploy various AI solutions on this platform. And these solutions essentially follow the patient's journey, right? So it starts from vulnerability mapping, which feeds into active case blinding using AI, screening for TB using cough sounds, which is really the next step in a patient's journey, diagnosis of drug-resistant TB through computer vision of LPA strips, line probe assay strips. And finally, once a patient is diagnosed, then tracking their adherence to medication using AI. So all of these AI technologies can be deployed and are possible because of integration into a platform like 𝐏𝐶, which is already scaled. So you're sort of piggybacking onto the scale. I'll just briefly outline current numbers we have in terms of the deployments that are scaled up in the TB space. We have an AI, as I mentioned, to predict adverse TB outcomes. These outcomes include loss to follow-up of TB patients as well as mortality. So we bucket them together. This is fully integrated into 𝐏𝐶. There's an AI risk score or a stratification that's available as part of 𝐿MIC. This model has done over 2 million inferences to date. It's not yet internet scale, but we've got millions of inferences. A third of AI-identified high-risk patients receive interventions, and this is mainly because of programmatic issues. Ideally, you want 100% of AI-identified high-risk patients to receive interventions. And what we find is that in patients that do receive an AI-enabled intervention, there's a greater than 30% reduction in adverse outcomes in these patients. And for patients that have more than one follow-up intervention that is again dictated by the AI, you get an additional 20% reduction in adverse outcomes. The second AI solution that we've developed that's scaled up is vulnerability mapping for TB, which is using AI to identify villages. Actually, the model identifies 500 by 500 meter tiles that are hotspots for TB across the country. And then these are aggregated at the village level. These predictions are aggregated at the village level. So we're identifying villages that are likely to yield higher than expected TB cases over and above the notification rates that are reported. And we've done predictions for 580 districts in a country of roughly 750 odd districts to prioritize active case finding activities for TB. And we find over 100% increase in TB patient yield following deployment of the AI. Now, this is not, the disclaimer is this is not a strict RCT, it's a before and after study. Cough Against TB is a cough-based screening solution for TB that's not yet massively deployed at scale, but it's still reasonable. We've got a reasonable number of patients who've used it, and it relies on using solicited cough sounds and patient-reported symptoms to screen for TB. There's no specialized equipment required. You can see how it's being used in the field in the picture over there. A health worker essentially has a phone, simple smartphone in the vicinity of the subject. The subject wears a mask, coughs into the phone. It's solicited cough sounds. You don't have to be coughing in order to do this. Noisy environments are okay. And it's been used to carry out 175,000 screenings so far across 85 districts. What we consistently find is a 13 to 17%, depending on the location and the deployment, we find a 13 to 17% increase in TB patient yield over standard symptom-based screening. It's not yet as good as X-ray-based screening. So the lessons we learned from the scale that we've achieved so far, not just from the TB solutions, but also other AI solutions that we've scaled up. One is, it's clear what doesn't work, and these may seem somewhat obvious in hindsight, but as in many other things, the most obvious lessons are not learned often. So what's clear is that models that are built largely on open source or synthetic data do not survive scale. They fail in deployment. Internal lab evaluations using, time-tested ML techniques, which are known to be theoretically good, like cross-validation, random holdout, etc., do not stand as proxies for real-world evaluations in a real-world deployment setting. And again, there's a number of reasons for this. Don't have really the time to get into them, but you can't use them as proxies. Cohortization of data is super important, both for training and for evaluations. Often you find that AI models are inadvertently trained on cohorts that suffer from selection bias. And all of these warts get revealed in a scaled deployment. Most important, adoption in public health is a very, very difficult problem. You can have the best solution in the world. That doesn't mean it's going to be adopted. It's mostly not a function of the accuracy of the AI. You cannot assume that because you have a good AI model that you made available either in open source or as a DPG, it will be adopted. There are many, many other hoops that you need to jump through in order to drive adoption. And finally, what doesn't work is impact evaluations that are carried out prematurely. So you really, impact evaluations that are carried out through a pilot mostly do not reflect real-world impact, which is a function of both adoption and accuracy. Usually in pilots, the adoption is forced, even though the accuracy may be the same. And so it doesn't, a pilot impact evaluation doesn't really assess what will happen on the ground. Now, on the other hand, what does seem to work, one is it's clear that you need stakeholder alignment, especially in public health applications. There are a number of stakeholders starting from the top to the bottom, and you need alignment across the board for AI to be successful. Especially because AI is an iterative technology, you need long and deep alignment. Piggybacking AI on an existing digital platform seems to work very well. Again, this just makes the adoption problem easier, just like the internet analogy from decades earlier. When these AI solutions got deployed on the internet, that just made a huge difference. Often we find that tuning the operating point is a cheap and quick way to adapt the model in a real-world setting while retraining happens at the back end. So if you see your models drifting, if you see data drifts, often you can temporarily solve these problems with a tuning of the operating point. And this is especially useful for screening applications. You need to push beyond open sourcing and DPGs, as I've said before, to get to scale. This is hard, but this is important. Very important to continuously monitor model performance. Again, seems obvious, but not done often enough. Thankfully, most of these health AI models do not have short lifetimes. If you look at models that are deployed on the internet, again, by contrast, they have lifetimes of a few days. In a few days, the errors just creep up, and then you have to retrain the model. That's not true in most cases in health models. But you still need continuous performance monitoring. This performance monitoring will require annotator bandwidth, and that should be budgeted in as part of deployment costs. And the models do need stability both in accuracy as well as adoption to realize impact. So any kind of impact evaluation should be done after the models have stabilized, both with respect to accuracy and with respect to adoption. So I'll end with this. Where are we in terms of AI in public health historically? As I've said before, still a new field. We're not at massive scale yet. India is the right country to achieve this type of massive scale, and it's just beginning. The success or failure of AI in this space will hinge on stick-to-itiveness. Essentially, the willingness of people and platforms to stay the course with AI through long and iterated deployment cycles. It's clear that AI does have a statistical value that will play out in the long term, but that doesn't always guarantee adoption. There's a number of other factors that come in. And finally, a short word about LLMs, where we know LLMs have value in a number of applications, and chatbots turn out to be the major application. But also agentic AI, LLMs used in agentic workflows should theoretically improve access to many non-LLM AI tools, right? So you can visualize these non-LLM models as tools in an agentic workflow. And this is going to be a very powerful construct going forward, although we still have to deal with hallucinations. That is not a solved problem. And I'm going to end there. Thank you very much for having me speak. Happy to take questions.
Sir, I just had a small question on what exactly you mean by TB patient yield that you mentioned in your study. And the second question is that we are actually involved, as a team, we are involved in developing a stool analysis, screening analysis model for diarrheal diseases in India. So I would like if you could give some suggestions on building the model as well and deploying it at scale also.
This is yield as defined by ACF activity. So essentially, you screen for TB, and then you find a yield, meaning how many more TB patients have you caught using this new technology versus the previous technology. So what we consistently find is, so these are patients who test TB positive in microbiological tests, right? What we consistently find is a 13 to 17% increase in patient yield. So we've caught more TB patients using AI-aided active case finding than standard case finding. This is a longer discussion. I think we need to have a this is essentially a metagenomics based testing. Oh, image based. Okay, no, then this is an even longer discussion. happy to take this offline if you can email me. Sure. You mean for the cuff, for the cuff screening? That's been that's been going on over the last 2 years. Right. So for the TB solutions, we've been partnering with the CTD and 𝐏𝐸𝐴 from the very beginning. I think from 6 years ago. For our non-TB work, we have done initial deployments without government partnership. Eventually, we do rely on something like a government partnership to achieve big scale. I think so for example, for the cuff based screening, the fact that we had the government partnership was extremely important for getting data. I think, we have the world's largest database for TB cuff sounds, TB labeled cuff sounds. And this would not have been possible without the government partnership. We actually, this data was collected from patients visiting, CTD-led health facilities across the country. We took cuff sounds from these patients for negative data. We took cuff sounds from TB health workers at scale from across the country. I can't see any other way we could have organized this type of massive data collection effort. Yeah, so I mean, you have to progress in stages, right? Initially, you want to make the AI as good as possible. So your success metrics are really standard AI-based success metrics. And then when you deploy, you really have to look at, adoption becomes the major thing. You can have a great model. If it's not being used, it's not creating impact. So then your success metrics have to include that, So at the end of the day, impact is going to be a function of both. Yeah. Thank you.
Thank you, Dr. Alpan. I now invite Dr. Geetha Manjunath to present.
Okay, this time, really good morning, everyone. Winter morning and wonderful talks by Dr. Karthik and the previous speaker. So what I guess we were asked to do, the next 3-4 of us who've been trying to make AI and healthcare innovation work on the ground, is to share a bit about our innovation and then say what we learned over it. And it's a real pleasure and privilege to present to the healthcare experts here and public health enthusiasts. So I'm Geetha, founder CEO of NIRAMAI, and some of you may already know about what we do here. But let me just spend first couple of minutes explaining what we do. NIRAMAI means being healthy. In Sanskrit, there is a saying, Sarve Santu Niramayaha, let everyone be healthy. So it's derived out of it. And we are trying to sort of change the way India and hopefully the world is addressing detection of the largest problem in women's health, which is breast cancer. It is the top cancer killer, as I call it. 680,000 women die every year because of this disease. While it's one of the most curable of all the diseases, we lose 50% of ladies detected with breast cancer within 2 to 5 years. The mortality rates are as high as that in developing countries mostly, right? In India, for example, last year, 2023, 2024, 2 lakh women got detected with breast cancer and 1 lakh women died. So it's like really crazy. It's one of the most curable of all the breast cancers. So what we're trying to enable is an AI-based solution for early detection, because obviously early detection means better treatment efficacy, reduced treatment costs, and better health of the person, and we can actually have her live long time after that. So we've developed this technology called Thermalytics, which is a combination of AI and thermal imaging. The use of thermal imaging for breast screening was around in very, very small pockets, particularly maximum of 500 doctors around the world are using it, where we can actually see early signals of abnormality in the breast with a temperature map. So essentially what the test does, actually I can't see anyone. I understand why he was moving to the side. It's really blocking. So what we do is just measure the temperature variations on the chest using a thermal sensor and convert the temperature map to a cancer health report using AI. We do not make the thermal imager. It is available off the shelf. It will be just like one of these cameras. This is an infrared imaging device, infrared camera to be precise. So we are purely a software AI-based medical device. So that obviously brings in a lot of challenges. People are used to, whenever you say medical device, it's something that can feel, touch, and now it's only AI being a medical device. So from there, the challenges start, but we'll get to the challenges and what is the approximate solution you've figured out. But with this and our AI models, we are able to detect very, very early cancers. 4 millimeter lesions have been detected. It does not depend on age and density, which is the current limitation of mammography and other techniques that are used today. Absolutely no radiation. We just measure the temperature, which is emanating, obviously infrared rays emanating from our body is what is captured. So it's a passive device which captures the radiation, more affordable. I say 10% of the cost and 30% more accurate. And that's what we ended up making it to be. And most importantly, it's portable. So you can take it out and do the screening in the rural areas or even urban areas where even screenings are not happening. And last but the best is also the experience of doing the test, where no one sees or touches the person when she's not wearing clothes. It's the primary, most important requirement for breast screening, but no other test actually provides this. And this was learning on the ground when we started doing the screening. We figured out the privacy angle being important and so on. So we create a temporary booth-like structure where the lady enters and no one else, not even a technician, is inside. It's like a changing room. She removes her clothes and she sits in front of the device and the technician gives instructions from outside. So this is the test. Just fast forward. Okay, yeah, I do have a quick view of the short video. So she enters. This is in a hospital setting, but close the curtain, sitting in front of the device and just rotating on the stool to capture 5 views. And these are uploaded onto the cloud. And the results are automatically generated. So that's the technology. Just keep it short, just as a reminder for some of you who might have heard about it before. I think the primary thing that was important for us to prove, given that this is first of its kind in the world, right, where AI is used on thermal scanning for actually generating a breast cancer health report, primary thing has been our clinical evidence generation, proving that it works as much as well as the current standard screening methodology. There's 2 ways to think about it. World Health Organization says for resource-constrained settings, breast cancer screening can be done and can only be done using clinical breast examination, just hand-based examination to look for symptoms and so on. So CBE is the recommended methodology. Having said that, the hand-based examination ends up detecting lesions which are 2 centimeters or 2.5 centimeters at the best, and that's already stage 2, 3. Yeah, it's good, but it's not good enough because we really want to save the life of the person. Which mammography, of course, is the default standard across the world, which can detect very small lesions. So our aim was to make it at least as good as, at least 10% non-inferior to mammography. So we actually make a difference better than hand, right? That was the thought process. So we initially set ourselves to compare the results of our solution with mammography. But mammography has low accuracy in dense tissue, which is young women. In India, actually, I'm just compressing everything, but India, we see very, very young women detected with breast cancer. The average age for breast cancer in India is 10 years younger than the rest of the world. Similarly, many of the Asian countries, because there is this different structure of the body which has dense tissue. And when the density of the breast is high, you can't use X-ray based test to detect variations because everything appears white and you can't find a white spot there. So, so usually people go for mammogram and ultrasound, both to put together. So first and foremost, what we did was set ourselves a very high goal of comparing our results, automatically generated AI results, with mammogram plus ultrasound being done. If mammogram is fully conclusive, then ultrasound is skipped. So what you're seeing is a head-to-head comparison of a prospective blinded study where the lady comes in, she takes our test first, the results are given, and then the same person goes and does a mammogram, and if need be, the second test, and if either one of them is positive, she goes for a biopsy. So this is the kind of very, very rigorous testing that we had to do to prove that, yes, we can use AI-based thermal imaging even in a hospital setting. Forget about the public health, right? That's another big of challenge. So to say this is a valid product or valid test to be used. So we spend a lot of time and energy and money as well in trying to sort of, getting this validated. It also, of course, given that thermal imaging is not so commonly available, we also had to collect these images for training our AI models as well in the similar fashion. So anyway, I'm happy to share that we now have 50 plus publications. One of them authored by Dr. Adapa sir, that is the Nature publication. It's not all authored by us, but so that's, and also most importantly, we focused on sensitivity. The idea was if we actually want to make a difference on the ground, it is like a screening, right? You can call it pre-screening also, where we want to filter out people who may not be high risk, right? So negative predictive value has to be very high. When we say no, it has to be no cancer. When we say yes, she needs to go for further testing. And that's the sort of the intended use of the device that we wanted. So we focus more on the sensitivity and negative predictive value, particularly for asymptomatic, but symptomatic also it turned out to be good. Then regulatory clearances are absolutely important. Otherwise, of course, you can't go to the markets. CDSCO was sufficient. At that time when we started, we actually, the company was created in 2017. We just last week, we completed 9 years. I don't know how it flew. But while India at that time, when we 2018 or so, there was no rule for AI-based software medical device, nothing. Like as long as the hardware is safe, you can add a software to it. So that's how it was initially. So thankfully, so we were able to do some of the testing with that kind of no objection certificate from CDSCO. But again, in 2020-ish or 21, they changed the rule and we went through the full rigor. And last year or so, we actually got a formal CDSCO license for Class C device as a cancer, software for cancer risk assessment, interpretive software, something like that. Essentially, we can officially use this for cancer risk assessment in the field. But what was interesting is that, yes, we did go for US FDA and CE mark because we were looking at international adoption as well. What was interesting is that when the US FDA approved it as an adjunct modality, that is when the hospitals in India started adopting. Anyway, so that shows the confidence of our own hospital systems on our own regulatory clearances. Several others, for example, because it is a software-only medical device, we need cybersecurity regulations to be cleared, ISO 27001, etc. And you need 13485 anyway to show that your quality management is suitable for scalable deployment. So far, of course, we have not scaled so well as much as I would have wanted it to be. So we are about 4 lakh, women who have benefited from this test. We are in about, I guess, close to 300 hospital locations, and thousands of screening camps done. Collaborated with multiple governments, including Punjab, Maharashtra, Karnataka, Meghalaya, and several other, Andhra Pradesh, and some of those have come in. So the way we work is, one is the hospital-based deployments, where it is offered just like mammogram or an ultrasound test is offered, as well as outreach. And that is where we are able to get more people to benefit, as obviously access is an important part. So here, because it's a very portable device, a person can put it in the backpack, take it out and do the screening in the rural areas. So it could be just in an auto or a two-wheeler, you can take it and do it. But we found that putting it into a mobile van also increases the mobility and access. So even inside a simple ambulance type of mobile, when we create the privacy, we wanted to maintain the privacy aware nature of it. So we create that kind of a private room and do it as well. Based on incoming interest, we have now have about 22 countries who are using our test in the initial framework. A lot of big hospitals have adopted. These are some of the names of the well-known ones: HCG, Apollo Clinic, Narayana Health, and others. And also corporate customers, we are seeing that so many women, even in big offices, were not getting screened for breast screening. And so we've done a lot of outreach in the hospital segment, in the corporate segment as well, where we have Google, Microsoft, Accenture, all of them, getting our tests done in their premises. Of course, when we do the rural outreach, we usually make it free of cost, sponsored by pharma or sponsored by CSR or government at this point in time. Now, focusing the next maybe 2-3 minutes of my, or maybe 5 minutes, on the rural aspect of it, the public health aspect. Of course, we've actually reached literally the corners, and I was very happy to see even in Uttarakhand, people walking up the really, really hilly regions, taking the, device up and then doing thousands of screenings in the corners of Northeast as well. It was really nice to see that. And one of the clinical evidence I wanted to bring up, and a successful project, is the Punjab project, which was briefly referred to by Dr. Karthik earlier. This is his paper, and the team from Punjab, which got one of the most referenced paper in Nature Public. What we show here is a very, very interesting aspect of how this compares with the currently standard way of screening in public health, screening for breast cancer in public, which is hand-based examination. So there are two triangles. I think all of you are familiar with this funnel diagram. Of course, there are a lot of challenges in follow-up. That's that's another different discussion on how to make people who are found to be high risk go and do the next level testing, right? So this is the initial screening. We were able to find about 3% of women, 15,000 women were screened, 3% of them were positive. And then out of that, only 32% formal diagnostic reports we have, though everybody was followed up on phone. We ended up finding at the end biopsy confirmed cases 27. Now, how does this compare with the current hand-based examination? There was another paper by 𝐿PAIGO, which is again another wonderful public health organization, for 50,000 women screened. Similar, better follow-up, but at the end they found 24 cancers. The top you'll see is 3 times more. Bottom is already more. That means we actually ended up finding 3 times more cancer than hand-based examination. So this itself is a motivation enough for us to say, yes, it works. This is something that we can really when we implement it at scale, it really make a difference on the ground, because there are so many women walking around, without knowing they have cancer, and they'll only detect when their blood oozing out or, huge lump and so on. So that was a very insightful aspect of it. So moving ahead, we wanted to put together a bunch of points on what are the learnings per se, as was mentioned by Dr. Adapa sir. What is the implementation science perspective, or overall, are there rules of the game, or is there any policy change that we can make based on this small effort that we have done from our own small company? So I put on multiple things. I have to see what all I've put in here. So first and foremost, and one primary important learning for me was definitely to be a responsible AI model. We definitely need to do adequate performance testing. I'll just go into a little bit more detail. That's why I double star on adequate performance testing. And this was a new learning as a computer scientist, to learn about how clinical testing is done and how do we move forward. So for that, I think some of the earlier speakers talked about it. Just cross-validation, ML model building in a lab is definitely not sufficient. That is only very, very early aspects of lab level testing that we can do. After that, because of the way the whole thing is structured, the data availability and so on, if it is possible for your AI model to do retrospective testing. Why I say that is, if you're working on existing images, then so many of the hospitals will have the existing images. It could be, let's say, X-ray or mammography images, MRI images, CT images. We didn't have the luxury because we were using thermal images and nobody else had that. Having said that, doing retrospective testing where you have the doctor's diagnosis available along with the data available, then of course first test out your models from that perspective. Then obviously prospective, right, which is blinded and so on and so forth, right, that's required. And if it is a medical device, there are some papers which show that for a medical device, if you have a prospective blinded head-to-head comparison, it is equivalent to an RCT. Why? Because what you do in RCT is that you take two different interventions and run it on two different subgroups, right, which have similar distribution of positivity. But that is required from a drug perspective, because you can't give the same two drugs to the same person. If a patient has taken drug number 1, the same patient taking drug number 2, you can't differentiate which drug made a difference. Whereas in a medical device setting, you can actually have the same person take both the tests, like I was mentioning earlier, and then get the same result. So what happens is that observational study, head-to-head comparison is actually becoming better than the RCT because you're testing on the same patient, right? But this is something we have to emphasize more. Many of the people, even in the hospital setting or they're not aware, or they're not able to think through this differentiation. If you go and say, here's the observation study on so many thousands of patients and it's a head-to-head comparison, oh no, I want RCT, right? So that, but actually this is better than RCT, the side comment. But yes, prospective validation, and then the real world valuation, and then the community rollout, and you'll also have to do a health technology assessment and so on and so forth. I'm sure many of you would have studied this probably in some course or something, but it was a real learning for me on the ground, because until then, I don't think we are being responsible AI model developers. So that's sort of going back to the double click on the adequate performance testing part of it. And of course, we can actually write up reports and so on until it is peer reviewed and published in, really high impact journal. Obviously, the results are not taken seriously. How do we position this in the clinical pathway? How do you integrate this in a clinical pathway? That becomes very, very important, because nobody wants any change. We want minimal change. We are willing to learn very little from a health system perspective. So how do we stick it in, right? Many places, can we train existing technicians? Can we train existing ANMs and so on, right? So that becomes important. So training of the staff could be one aspect. In the flow itself, when patients come in, where do you place this? That becomes important, etc. And when the doctors have to see the result, when you find a person to be positive and you take it to ask them to go to the next level testing, we found in some cases they're again doing CBE. Oh, I can't find a lump. You go back home, you're fine. So what is the use of finding these 2/3 more cancer patients? So you have to explain to the doctor, this is why we feel there is some abnormality. Please do the next level testing, right? So that explainability of results is very, very important. Transparency in the operation is also very important. So we actually gave, I think there was this slide that Dr. Karthik put up about usability at different angle, right? So you have to have kind of windows in your AI model, if you will, right? And if you have stages, some of you would have developed, you will know, right? You have to have those sort of explainable or transparency windows, right, through which you can let the doctor see what's happening and I can discuss offline as to how do we do this. A simple example is we use deep learning models, right? You have these features are really not interpretable. It was 0.0013 into 10 power 13. When doctor said, is it high or low? I don't know. So we have to innovate to make that number a number between 1 to 10. Above 5 is bad, below 5 is good. So discretization of deep learned features was another patent that we have 39 patents in this whole process of doing this, right? So that was one patent. We got a US patent for that as well. So there is a lot more to be done, but explainability includes several other aspects. And marking the area of lesion, that is also one way of explaining, because there is an actionable thing that you can do of it. There are more. What is very interesting is the scalability of, I mean, like all of us shun quality processes and so on, but actually the ISO 13485 we went forward to where we've sort of streamlined whole thing was really useful. If now somebody says, I want 100 devices or 1,000 devices, I'm very confident my small team can actually deliver it without any issue with all the process points put together. That is thanks to the SOPs because of the quality management system. So earlier itself, in your whatever effort you're doing, bring in these processes into the picture. It does look like an overhead in the beginning, but really, I tell you, it kind of really helps us scale. Several others, and I'll just talk about the innovative business model. So obviously, we are startups. We need funding, and we need to be as self-reliant as possible. So if a hospital is offering mammogram as 3,500 rupees and we are able to detect cancer with non-inferiority as shown before, so why should I leave the money on the table? So the hospital, our hospitals charge half the price of mammogram. But of course, even 1,500 is a lot of money for end users in the rural segment. So we kind of innovated in the way we do the reporting itself, right? We have a triage reporting and a 360 reporting, like the 3-4 reporting models, like a fridge with double door or single door types. So you have different product models, and we charge them at different levels. And this was considered very innovative, and even Harvard Business Review has done a publication on this. So several other aspects we had to sort of go through this, and in the interest of time, one last aspect is improving access. Is a very, very simple term, but I felt that it is actually a combination of affordability, acceptability by the end user, and also making it available at the right time to the right people. So it's like it's a very loaded word actually, and we need to take care of it. So yeah, I just put on multiple papers and different levels I mentioned here, right? Retrospective testing, prospective testing. So these are some of our real papers going through the full cycle of post-market community rollout, where again we have stopped publishing. But right now, we have just started a very large-scale RCT style 7,000 patients data with the funding coming in, and so on and so forth, with KEM Hospital being in this center. So you cannot start with an RCT because of the funding limitations and all mentioned. But if you actually follow the right pathway and create evidence in a stepwise fashion, it goes through. Last slide. In terms of the adoption itself, accepting on the ground and getting acceptability on the ground, etc. I think we can think about, if I look at it like a hindsight, how we have sort of progressed. There are 3 phases. First phase was showing and convincing ourselves that the product works, the clinical studies inside the hospitals, comparing with biopsy, privacy is brought in, all of that. That is product market fit from a public health perspective as well. The second one is the early community adoption. So here, primarily a working model. In the first case, I remember doing all the screenings myself and learning on the ground what is the gap, etc. The second one is where you actually train, simple healthcare workers to be able to train them, to give them certificates of being proficient enough to do the screening, etc. And then we realized that there are a lot of mistakes they're making. So we had to innovate on even how do we ensure that images that are coming in are of high quality. We had like 4 or 5 patents in that area already about figuring out if the person is sitting in the right position. It's an imaging-based test. Is some view missing and some precondition not done? So all that is automatically checked. Again, deep learning models for that. And then we figured out that if you actually want to have doctor in the loop for everything, it's not going to work. The AI model should be so accurate and high negative predictive value, as I said, that we can do instant triaging and doctor is coming in only for positive patients. While that is the need, your AI models have to be really good to be able to promise that. And that we were able to do in the second, where the partnerships were with Karnataka Cancer Society, Rotary, and some of these NGOs, where they were helping us actually go and get to the real place where it's needed, etc. And certain government pilots also. The phase 3 is like much, much larger rollout, where we figured out that we had to even reduce the cost of the equipment and so on. So we started working on lower resolution camera models and improving our AI to work on that. There were mobilization challenges. So how do you mobilize? By taking the horse? We'll say, if horse doesn't come to the water, take the water to the horse. So how do we sort of, take it to them? So that was another aspect that came in. We are still working on the patient navigation aspects of it, reducing the dropouts and improving the referrals. For this, we've just recently developed patient navigation software where we can really track what did the person say when we called and so on and so forth. And just recently, the second phase, Punjab is starting to use that navigation software. By the way, the navigation software was developed using Replit ChatGPT or GPT version. And so on and so forth. So the third phase is mostly with larger system health system integrators, where when you go to the crowd, you don't want to do just breast screening. They want to do cervical screening. They want to do anemia check and so on. So you need to work with partners who can offer really high quality point of care, similar or complementary disease screenings for the similar cohort, right? So that is what we are in the last phase now, and we've had a bunch of this integrated solutions going in. Anyway, these are some of my blabberings and about just sort of thinking about what did we learn, but open to ideas and collaborations beyond this. Thank you so much. Hope it was helpful in some fashion. Okay.
Thank you, Ashoka University and all the partners for inviting us here for this talk today. Thank you, Dr. Adapa, for the wonderful onset to the topic. And I'm really happy to see that many of my peers are here today presenting their experiences. And you may see me shivering. That's just because I'm riding the beast that Dr. Patan Shetty mentioned earlier, or the tsunami that Dr. Raval mentioned earlier. So pardon me. Just kidding. So I'm Veena Moktali. I'm the co-founder and CEO of Periwinkle Technologies, and our product is called the SmartScope CX. CX stands for cervix. So SmartScope CX is a complete system for cervical cancer prevention. We are already a US FDA approved, CDSCO approved, as well as all the regulatory approvals from many countries. We've also been the winner of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana 2020 Grand Challenge winner. And of course, there have been several other global accolades and recognition as well. We are officially a part of the UN 2.0 now, I'm happy to say. So before I jump onto my new, the slide that talks about the topics that are relevant to today's discussion, I would like to tell you what the SmartScope is. Today, many of the women here may have experienced that you have to go for
a regular pap smear or you have to go for HPV DNA tests. But you can imagine that many, almost 90% of the women in this world don't have that privilege. In fact, women from developed countries also have mortality because they don't get themselves tested in time. In fact, one of the countries like the US or even in the EU, if you have to get the appointment of a gynecologist, you have to wait for 6 months, right? You have to take an appointment, then you can go there. So you have to have your cervical check only on a scheduled basis. If you want to randomly go and get yourself tested because you have some problem, you of course won't find an appointment quickly. So with all this, back in 2013, we started working with Tata Memorial Centre in Mumbai, and we saw many patients coming from various parts of the country for getting treated. And while we met one such patient who had come from Manipur, she had actually undergone an operation and she was begging on the streets. So when we asked the doctor as she was walking us out why she's begging on the street and what is wrong exactly, what makes these patients come here and beg, she said that the treatment is at a late stage, and of course the mortality is high in the country. Prognosis is late for the women who come. Prognosis is poor for the women who come to the healthcare because it happens very late in stage. So public healthcare in India, as well as many LMICs, is looking for something that gives a single visit result. When a woman comes into the healthcare, either as a symptomatic woman for some specific problem resolution, or as an asymptomatic woman who has been getting checked up opportunistically, you need a single visit result which will tell her if something is wrong with her cervix. And I'm pretty sure everybody here knows what's the cervix. It's the mouth of the uterus. Of course, pap smear has been around for almost 100 years now, right? 80 years. So pap smear still had a lot of problems in countries like the NHS. In fact, had a big case going on because pap smear had false negatives, and the cancer was developed over a period of time, and the woman sued the system saying that how could you not detect it at early stages. So this is the problem with manual testing. So that's why we developed something over a period of years of market research. We didn't immediately go and develop a handheld colposcope that the doctors wanted. We actually went back into the system. We went to the field level. We in fact worked with quite a few different types of healthcare experts, public healthcare experts, oncology experts, gynecologists who had nothing to do with oncology, and even the frontline workers, to understand exactly what did this single visit testing mean. And it actually meant a handheld small device that a nurse or an auxiliary nurse midwife could use, along with an AI and a strong system of referral pathways. So loss to follow-ups in public healthcare don't happen just at the diagnostic stage. They also happen up till the clinical intervention, the treatment, and the subsequent repeated checkups. So we wanted to reduce all of that because these follow-ups were causing all these many deaths. Every 2 minutes, one woman in the world is dying somewhere because she didn't get diagnosed at an early stage and she didn't get followed up later on. So this is what the smart scope looks like. As you can see, the nurse is holding a small probe-like camera in her hand, which is connected to a tablet. It comes in a small carry case which weighs about 1 kilo. So that means she could easily carry it into the community. It does not require internet. It does not require running electricity. It does not require any specific setting, no light conditions, no temperature conditions, nothing. It does not even require a lithotomy chair. All it requires is a flat surface. Ideally, this examination could even be performed at home on the floor. So all it requires is for the nurse to insert a cusco speculum, and that's a skill that we train our users to do if they are not already used to it. And she takes pictures of the cervix at 3 different stages. So there's already a method called the colposcopy, which is very well established in the world, which is used by experts to do confirmatory analysis. We miniaturized the whole thing and we built an AI based on the principles of colposcopy. So what that means is now the woman who's getting tested here has an access to a colposcopy grade AI right there, and she will be not just be screened for whether she has cancer or no cancer. She'll also have a better understanding of the health of her cervix, what other reproductive tract infections are there, whether there's a polyp, whether there's an inflammation or any other health condition which could make her cervix vulnerable to viruses such as the HPV, which are one of the major reasons of the cervical cancer. So this also meant that we could encourage more women to come forth for getting themselves tested. So inclusion of the entire population was always on our minds right from the beginning. We never wanted to test only the symptomatic women. We also thought that this report, which the nurse is going to generate for this woman, should be very easy for her to explain and for the beneficiary to understand, because nurse, of course, does not have the technical skill to explain all the nitty-gritty of the health of the cervix. She perhaps may not understand some of the terminologies herself, and the woman herself will not understand what to do next in case a specific condition is found. So what we did was we did a color-coded reporting right from the various grades of pre-cancer as well as benign conditions. So SmartScope detects pre-cancers, which is earlier stages of cancer before it becomes carcinoma in situ. And that's why with cervical cancer, the biggest advantage is that if you detect it at the pre-cancerous stage, you can treat it really well. The treatments are very affordable. In fact, some of them can even be done in the outpatient department. The woman doesn't have to have a lot of hassle of repeated visits or out-of-pocket expenses. So with all this, all these points in mind, we designed the hardware, we designed the software, we designed the AI, we did the data collection, and we had the prospective studies over a number of years. Eventually, we had, of course, started working with a few public healthcare systems, because right from the beginning, our focus has always been the villages. Our focus has always been the communities. So we started working with a larger number of communities, different states, because different states had different needs, not just from the ethnicity testing perspective, but also because their usage parameters were very different. And this is something that we wanted to understand very well before we took it to an even bigger scale. So for example, somebody who tested these women in a hilly region in the northeast versus somebody who tested on the islands of Lakshadweep would be very, very different, right? I mean, their use cases would be different. So what is the user experience that actually causes your product to succeed or fail? This is something that we wanted to understand right from the beginning. Of course, while doing all this, all of our users always had concerns about whether their data is being used for training the AI. And that's a very common question that I'm pretty sure all of the AI developers here get. Do you use my data to train the AI? And we had to assure them that no, our AI is trained on the clinical data that we get from the studies where the agreement has been made with the clinical partners, where we have ground truth that can be used to train the AI. From field studies where sometimes you don't even get biopsies, we don't use the data to train the AI. So whatever work we are doing with our customers in the pilots is mainly to understand how the product is fitting well into their systems. Secondly, we always got questions about version control. So they would ask, in the initial days, we had generation 1 AI, generation 2 AI, and then over a period of time, now we have generation 4 AI going on. And of course, that doesn't happen very quickly. It takes about a year to year and a half to come up with a new generation of AI. And in that, a new data set would be there, a different strategy would be there, often messaging outputs, everything would be different out of that. So we had to be very transparent when reporting to our users. Even during clinical studies, we did that, and that's the same practice we continued in our pilots as well. So as a result, SmartScope has become a very, very user-friendly, very, very scalable point of care testing method for cervical health. It does not require any infrastructure. It we can onboard our stakeholders, and that does not include just the users, by the way. Healthcare has many stakeholders, right? From the beneficiary, the end user, like the midwives or the CHOs, the community health officers, or the frontline workers such as ASHA workers who are mobilizing these patients, or it could even be the gynecology experts who are actually triaging them remotely. It could be administrators who are actually putting together a program. We had to educate all of them about what this AI is doing and what it is not doing. We had to set their expectations right. Of course, we had to be very considerate of the economic settings. So therefore, the AI would always give the result depending on what the clinician or the end user is expecting out of it. So for example, if there is a oncologist who's using the AI, there would be more details shown, whereas when a nurse midwife is using the AI, a different view is shown. Although the information is all there in the background, but what is shown is, of course, depending on the setting, because then what happens next to this, let's say, suspect positive woman would depend entirely on what is being said. So the messaging was very, very important. And of course, the SmartScope CX works in all populations because its underlying principle is the scientific principle of colposcopy. We had to understand the user behavior, which is very different in the Indian public healthcare settings. And even within India, in the private healthcare settings and the public healthcare settings, there's a lot of difference. So therefore, some of the Western scientific methods or frameworks really don't work well for us. So this is one of the things we understood as we went along. The data environments are very, very different in our case. In many places, they don't have something like HMIS, whereas nowadays we also have the Ayushman Bharat digital mission. We are also expected to integrate with that, and I'm happy to say that we do integrate with that and many of the HMISs as well. There are also workflows and protocols which are very, very different, and what is expected to be done for a patient who's given a result of amber color, let's say, that means benign condition, is very different from somebody who has a low-grade lesion, which is again very different from somebody who has a high-grade lesion. So this differentiation had to be very clear in our minds. While we did all that, we always gave a mechanism to monitor these results. We have always had a remote expert review built into our system just because we wanted that human plus AI collaboration right from the beginning. It's there by design. And of course, the subsequent enforcement of the right frameworks also has to be done by the administrative teams that are part of the program. So, yeah, these are a few of the things that as part of the learnings, I would say that it's not just the AI that learns. It's also us humans who learn with how the AI behaves or how the AI is used. So we must also incorporate some of our learnings into how the AI is designed as a system. Risk mitigation has to be there by design and also by training. It should not come as an afterthought. We should also have the best practices for accountability, but at the same time, we should have very, very clear definition of where the liability lies. The IARC, the International Association of Research on Cancer, has themselves, they have admitted that it's a gray area who the liability lies with when a pap smear report goes wrong, right? So should the lab be blamed? Should the gynecologist be blamed for taking the wrong sample? Or should it be somebody else altogether, right? So nobody knows. In the legal frameworks, this is very difficult to defend. But at the same time, as developers of the AI, we ourselves, of course, have the responsibility to ensure that it is performing well before it is deployed in pilots and subsequently scaled. But then it's a collaborative effort to ensure that it keeps performing the same and there is no algorithmic drift, because then the user environments could be very, very different. So it's a collaborative effort and that has to be recognized by everybody. So that's it from my side. Thank you so very much. I'm happy to answer any questions later.
Now I'd like to invite Dr. Anand Sivaraman to present.
Thank you so much. Thanks, Girish. Even as I was walking in, I think 5 minutes before, Girish came to me and said, keep yourself to 10 minutes. So I think one of the things that he's made it difficult is a lot of what we are going to talk about is work that's taken around 6 years in being able to develop, deploy, and then look at the impact of the implementation research. We are going to compress that to 10 minutes. So what that means is there'll be some slides which are more about context setting. So I'll be rushing through those. But the most important slide is what we are trying to do is to see, can we come up with a framework out of what has been done so far? And that's where I'm going to be spending a lot of time on. We have close to 80 plus clinical publications, peer research publications, and public health impact publications, all of which are open access. So including in journals that are not open access, but where we are paid for to make sure that it's open access. So please feel free to go to remidio.com for where all of these are available. In case that you would like to get into details of some of those slides where I may be going through with a certain bit of a pace or speed. Now, what's most important is you will not see the word medical device, you will not see the word AI in the title, because as a public health company, we feel that those are technologies which are a means to an end. And what we are focused on really is to ask the question on outcomes. Have we really had an impact from the point of view of not eliminating? Earlier, I would use the word eliminating needless blindness. But we've been humbled over the past 6 years of working at the grassroots that you can reduce. It's much more difficult to eliminate. And that is something that we'll talk about as well. So what Remidio is focused on is to ask the question, can we look at being able to reduce preventable blindness due to 3 conditions that are the most common chronic retinal conditions that can lead to blindness? So this is just to give you and set a context in terms of numbers. All 3 put together, what's important is not the fact, the percentages of course are there, but what's important is the number of people that need to be screened for them is roughly around 400 million in India. 400 million adults need to be screened for this condition. And when you think in terms of diabetic retinopathy, glaucoma, as well as age-related macular degeneration, I'm going to be talking about the work that we've done with the government of Kerala. And therefore, what's very important here is also to see that there are certain Kerala specific, and I think some of the speakers did talk about the fact that India is heterogeneous, and therefore state to state there are also differences in the way the impact populations are and who do you need to design for. So here it's really a lot. It's nearly 5 million who are 40 plus and a large density of elderly population, and the prevalence actually is higher than the national average. The national average for diabetes is around 12 to 17%, and in Kerala it's between 20 to 22%. Now, the case that we make is for eye screening, and increasingly we use the word triaging rather than screening. The case is for eye screening or triaging to be moved to a non-specialist context. And what do we mean by that? One is today 70% of an ophthalmologist's time is actually spent in finding out who has a problem. We think that can be task shifted to the health workers, and the time can be spent for the specialist and actually on treatment and monitoring and follow-up. The second is the fact that, and this is data that we've also published, that 99% of those who today have a chronic retinal condition do not know that they have it, because by the time that they know they have it, when it starts affecting their vision and they manifest clinical symptoms, it's too late. You need to detect at a time before there is a loss in vision as a result of that underlying condition. And therefore, it's very important to identify, screen and risk triage in the community as opposed to waiting for them walking into an ophthalmologist or a specialist clinic. And lastly, and this is sort of something that we are now publishing on, where we have seen that the use of AI, in a way, we were asking the more important question, which is, can detection and the use of AI increase the number that actually come for treatment, which is the second part of the research that we'll be talking about as well. And what we see is the fact that we are able to impact what's called the referral behavior of a patient from a point of screening to point of care. Because one of the things we believe is it's great doing screening, it's great doing triaging, but unless we close the loop with a care gap closure, really you're not really having the public health impact that I think we all seek. So, what has there been, the first question we asked ourselves is, let's take diabetic retinopathy as one condition. Has there been any public health system, or has there been any health system that has actually eliminated diabetic retinopathy as a reason for blindness in working age adults? There was NHS in UK. And so we said, okay, there is some health system that has done this. Can we look at being able to learn from that health system, but appropriately modify what they have done so that you can do the same thing in India, with Kerala being the test bed of where we wanted to do this. So one of the key things that we therefore did was to ask the question, can we replicate this model? But obviously we knew that the affordability index is very different. Just to give you numbers, it's £40 per patient to screen someone for diabetic retinopathy in the UK, and between £700 to £1,300 per injection if you want to actually treat them with anti-VEGF for those that are detected to have stages of retinopathy that needs that treatment. And we set ourselves a goal where we said that the cost of this, which is the screening plus treatment, has to come down to somewhere around $5, which is roughly around 400 rupees. Yes, in the past few days, there's been an devaluation, but roughly 400 to 500 rupees is what we wanted to look at a population level of the cost of not only screening plus treatment. So that's really what our focus was on. The next is simplicity, and the reason this is very extremely important is if you're task shifting detection to health to the ASHA workers or the those in the public health system, the devices have to be extremely simple to use. The solutions have to be extremely simple to use. And the last was, traditionally the way you would do screening is images of your retina are taken without doing any dilation. These are sent to an ophthalmologist who would actually indicate whether or not you may have referable forms of the disease. Now, to give you a sense, we need 400 million that need to be screened. We have 15,000 ophthalmologists. There is no way that you would be able to scale the screening. So we realized very early that it is not going to be possible for us to do it with specialized graders, as was done in the UK. To give you some context, roughly 5 million in the UK are screened for diabetic retinopathy among the roughly around 12 to 13,000 optometrists plus ophthalmologists there. There is optometry as an additional field that is available there for those who can actually screen. So therefore, when we frame the problem, because I think a lot of us who are technologists, me included, we love solutions, but my lash on the back usually is you need to know how to frame the problem correctly, more importantly than the solution itself. So what we designed is you have these bulky devices that are available within an ophthalmologist context. What we were able to do is to miniaturize that, and without compromising on clinical sensitivity and specificity and accuracy, and be able to attach it to the back of a smartphone. So really you have the optics, which is where our patterns are, and the images are actually taken by a smartphone, and now you get the same clinical grade images as what you would get from these big devices. But the challenge is to see how they perform in the hands of the health workers to whom you're going to task shift this to. So that was the most important question. Of course, what we also said was, this was way back in 2019-20 when AI and deep learning models were coming into vogue. But at that time, it was very clear to us that we would have to design this using the constraints in an LMIC as an opportunity to innovate. Now, what does that mean? These are all battery operated, so they can work without needing electricity. The AI algorithms run on the edge. You don't need an internet to send the images to the cloud for the algorithms to run on the cloud and come back. So each of these algorithms therefore work on the edge, where you get the interpretation within 5 seconds of taking an image. You would know whether you have glaucoma, diabetic retinopathy, or macular degeneration, so that it can inform the next part of the pathway. Now, these are a number of publications by which we were first able to show that the hardware performs as well. And these are context and out of context studies that had to be done. What do I mean by that? You first have to show that the same patient on a traditional device versus this device has the same clinical outcome in terms of diagnosis in an ophthalmologist clinic. The next study that had to be done is the device used in the hands of a health worker and the same patient being brought to an ophthalmologist, you still don't have clinical outcome differences, which is really a lot of those studies that we had to get done on. The next after that was to ask the question, this is great. So far you've generated the clinical evidence, but now let's get into implementation research and implementation science. So we said, let's go back to NHS. Why was it important for us to go to NHS? We designed a technology. At the end of the day, there's a conflict of interest if we start building programs around the technology ourselves as well. So we said, let's go to that health system that has actually been able to eliminate diabetic retinopathy in working age adults. Can we take protocols and programs that they used to bring them into being able to use these technologies? And in the government of Kerala, we had a willing partner that basically said, show us what you can show us as impact. And there it was not about clinical impact. It was also about ROI, or return on investment. So we'll be talking about how we had to do health economic analysis to actually show whether or not there is been an impact on the economic side as well. So we took the district of Trivandrum and took 20 family health centers. These are family health centers, very similar to what you would call as public health centers. And we actually did, over a period of 3 years, 4,000 patients in 16 family health centers. And what was very interesting is the total number of patients with diabetes in Kerala is roughly around 7.2 million, which is 1 to 1.5 million more than the number of patients with diabetes in the whole country of UK, right? So in a way, we knew that the size was similar. So if someone solved it for 6 million, let's see whether we are able to customize that and solve that for a similar size population that we were looking at. And of course, the stakeholders were us. We were responsible for training the health workers, district hospitals, as well as the tertiary care hospitals, because we did not want to just screen. We had to know what would you do if you detect someone having disease, what next? So therefore, the program had to be done, or the implementation science research had to be done by actually having a pathway. And this is extremely important, as what Dr. Karthik talked about, that technology is one part or a very small portion of the entire pathway. So how do you integrate yourself in the screening pathway? And then post-screening, how do you integrate yourself in the referral pathway? So we had to create the referral pathways as well. And what was nice is, the referral pathway means if you have mild diabetic retinopathy, what would you do? Moderate, what would you do? What would you do in case you had severe? Similarly, what would you do for early, moderate and advanced glaucoma and macular degeneration? So this was a pathway that was created. And post that, these were the results of it, a 3-year study by which we found that 1 in 3 patients who had diabetes did not know that they had diabetic retinopathy. 99% of the patients that were detected with disease did not know they had disease. 8.3% was referred, and that's where epidemiology comes in. For the first time, we were getting epidemiology data at the level of a family health center, which serves a population of around 50,000. And most importantly, we were able to find that the cost of screening and treatment put together was around 400 rupees, which is the cost of detecting disease and treating them for the disease with either laser or anti-VEGF injections. Now, what's very important when you think at a population level is those who don't have disease are in a way subsidizing for those who have disease. That's really where population deployments have significant advantage in terms of the economics. And lastly, of course, what was nice is the fact that the government of Kerala said, look, this 16 data looks good. Let's now scale from 16 to 243 family health centers. That's the next part of what happened. For the first time, we started getting registry data. What does that mean? Because there's a chronic disease, you need to screen them every year. You have a diabetes registry in Kerala, but now we have a diabetic retinopathy registry. We also have a glaucoma registry, as a result of which follow-ups can be done on an annual basis. So what was very interesting is all of a sudden we realized there are certain districts that have higher prevalence than certain other parts or certain other family health centers in the same district. So there was between districts and within districts differences that we started observing as well. Now, what's also very interesting is, roughly, if there are 100 million patients with diabetes, you expect epidemiologically around 6 million to actually have macular edema, which requires what is called anti-VEGF injections. Interestingly, the total number of anti-VEGF injections that are actually given in India is less than 1 million. So where are these 5 million? actually going. That's really a problem that pharma started coming to us and solving. So we realized that in solving a public health problem, you're also solving a discovery problem for others in the ecosystem. Now, this is something that we published, and when we went from 16 to 2 days, we realized we can't do teleophthalmology because we're going at scale now. So very quickly, we had to implement, we had AI-based solutions. And so this is that slide that I'm going to be spending a lot of time on, primarily in trying to reduce it to a framework in terms of how we develop the AI. I think the first parts are very similar to what was talked about in terms of how do you curate data, how do you actually ensure that you train the data, and then after that, how do you define clinical endpoints? Now, the point that I wanted to spend some time on is the one on defining minimum performance criteria, right? Now, most cases, the minimum performance criteria for an algorithm is informed not only on the basis of clinical, but it's also on the basis of the health economics, right? If you have very high sensitivity, but you're compromising specificity, you're going to overburden a system with referrals that are unwarranted. At the same time, that also has a cost implication to it. So it was a balance that we had to do on the basis of understanding. Now, what's important is to the regulator like CDSCO, they asked what are other health systems doing. So they used FDA mandated clinical endpoints of 82.5% and 85%. But that comes from a population research that's very different from what is done in India. So one of the key challenges that we have to look at is how do you actually come up objectively with these endpoint measures that is informed actually not by having just clinicians and technology innovators. You need representatives of the patient. You need representatives who come from a public health background to ask the question in terms of what is the minimum that you want to set as benchmarking for the performance of these algorithms. The second is, of course, as we move towards the right in terms of the other parts, I think to a certain extent, we do know about some of the frameworks that are used on the clinical studies, whether it's the Desired AI framework or you have right now the tripod framework, but or what I think Dr. Karthik talked about in terms of how the human factors interaction comes in as part of the salient framework. But what I wanted to focus on is the last part there. And this comes in where I think there was a nice slide where we talked about the gap that you have in a pharmaceutical product process versus how do you actually fill the gap for AI. Now, our learning has been the fact that when you do the implementation research trials, there are 5 aspects that you have to look at. How valid is what you've done within the lab relevant on the field? That is really the validity part. Now, usefulness is actually highly subjective, right? Because at the end of the day, utility can be looked at in terms of asking the question, have you detected more that have the problem? Or have you been able to detect more and close the loop in terms of giving them treatment? Because at the end of the day, we've seen by doing this the right way, you can just create fear in a population by just detecting them. Unless and otherwise you close the care gap loop, it becomes very important. That's a responsibility I think we all carry as we bring in new technologies to the last mile. So that was very, very important. Of course, there was the questions around transparency in our case because of the fact that the data never left the devices. The data, so the AI was running on the device itself. So it was privacy preserving that way. And most importantly, the question on equity and bias, we actually learned it the hard way. I'm not sure this is just anecdotal for you. If you go and take a look at every retinal camera that is manufactured globally, you will find that the minimum pupil size for which they are designed for is 3.3 millimeters. Why not 3 millimeters? Why not 4 millimeters? We didn't understand. But then we realized the average distribution of size of a Caucasian eye's pupil is 3.3 millimeters. In the developing world and in LMICs and those of us who have dark iris, the smallest pupil size is 2.6 millimeters and lower. So all of a sudden now, we realized we designed for a system which was very different from what is actually seen in many of these populations. So we had to therefore go back and design the hardware to go to much smaller pupil sizes and go back into the study. So those were some of the learnings that we had. But the reason why it's important to bring that in is coming back to the point that I made, that the way we framed the problem, because all of a sudden what this means is if you are confronted with a public health problem where someone is coming in with a significant risk of diabetic retinopathy, will you dilate them in a public health context? Or are you going to tell them automatic referral because I'm not able to image you? both of which are not necessarily something which is easy to take a decision on. So what was very interesting is we then went in to look at the risk of what's called angle closure glaucoma as a result of doing dilation. And what was nice was the government of Kerala, along with Arvind, L.V. Prasad, and we went back to the ophthalmic mission-driven organizations, and we were able to show that it is okay to actually dilate without something called phenylephrine, which is responsible for actually causing an angle closure glaucoma attack. And what was interesting is we picked up a lot of small pupils where there was disease that we would have missed if, let us say, we had not actually screened them properly by actually putting in a drop. So those were some of the learnings that came about. And in fact, what's nice is the fact that now NHS as well as Scotland has also taken this as part of, so this is learning from India going outside in a way as part of the implementation science. So lastly, of course, we've talked about some of the clinical and the other part to it as well. Well, this is pretty common in terms of what you would look at with basic principles. The last part that I wanted to focus on was utilization, which is an important part in how you would assess whether or not the devices are being used and whether or not there is impact. And what was nice out of the entire Kerala exercise is we had to publish guidelines for use of screening and using AI. And the All India Ophthalmology Society, along with RSSDI, published these guidelines. These guidelines eventually resulted in reimbursements from the government in terms of ABD and PMJ, where today there are reimbursements for any clinician to actually be able to do screening of the eye in public health context. And they are pretty sizable reimbursements of up to 800 rupees to 1,250 rupees per patient who actually is being screened for these conditions. So I'll leave it at that. And the most important part of what I wanted to talk about was this. Interestingly, these are open label, similar to the RCT trials. This was done by NHS UK on 7 different algorithms, including ours. And this was made possible where they are basically looking at whether or not there is gender bias in the AI algorithm, whether there is any age-related bias and ethnicity bias. What is very interesting is the top 1, 2, 3, 4, which have very high sensitivity and low specificity, are those that come from the West. The bottom are the ones that are coming from LMICs. What is very, very interesting is you're starting to see the fact that in the West, the medical legal is such that you want very high sensitivities. You overburden a system, but the system already can handle it. Therefore, you need to start thinking in terms of what should be the right clinical endpoints that you need to start using. And it's been really nice to have the NHS actually do these independent trials, but I think we need to start doing these here as well, as a way by which you're able to define what is good from a public health perspective. So I'll stop at that, but thanks so much for the time and thanks for the opportunity.
Thank you, Dr. Anand. Now, I would like to request Dr. Shantanu to please present.
Hello, everyone. I'll try my best to finish in 10 minutes. I think there's a new benchmark. We used to be known for 5 minutes. Now we are known for 10 minutes. I'll do my justice at the best. So at Doto Health, we primarily offer digital health solutions for pregnancy and newborn care. Our journey has been to start with, a complete connected care. From there to data generation and the AI model. So the one of the speakers said was, we are at a very nascent stage as a country in AI, and that stands true for us as well. I think most of our reflections are the AI is used for triaging as a primary tool, but not doing any risky job at this stage, and because there's still a lot of validation that is required. For us, the motivation was to simply start with by zooming in why we are losing mothers and babies. That too particularly a 24-hour window, or basically during labor and birth and immediately 24 hours after that. That's where maximum maternal and newborn deaths are happening. However, the journey doesn't just start with that. It starts when the baby is conceived or mother is pregnant. From that point, identifying risk at an early stage, able to also spot a certain clinical risk which will lead to complications during labor and birthing, and most importantly, overcoming certain skills gap or the resource or the information gap, which leads to complications during this period of the journey. And that's where we saw that if we are able to bridge certain gaps for knowing the risk, communicating the information in a timely manner, at the last mile, there is a role for technology to play. And that's where our first intervention on last mile care kit with point of care screening devices, with basic algorithm first to understand the risk at the field level, and then communicating that information to the higher stage for mapping the risk, and now then taking this data for risk stratification. So as I said, the journey started with very simple problem statement that can I initiate the access at the last mile and identify the risk. The second, during the labor and birthing period, the problem that we noticed was primarily, like Anand mentioned, bulky devices designed for bigger hospital settings, not able to move from one place to other. Rather, one of my first exploration was a mother was taking from a different ward, literally in the different building, to a room which was defined as NST or CTG room, like for monitoring the fetal heart rate, because the machine was placed there and it was so delicate, the wires were almost broken. So the mother has to come in an active labor phase from one room to other room just because the machine can't be moved. And those were the simple question as a technologist that, can we first address these fundamental issues and go to the next level. The next level was the subjectivity or inter-observer variability among clinicians to interpret what we call cardiotocography tests. And this still remains the bigger challenge. And conveniently, with certain limitations, the machine is put on the wrist saying that this machine increases the C-section rate, which I sometimes see why machine is doing that job. The third is also very important issue during labor and birthing is fatigue or workload of monitoring a mother right from minimum say 6 hours on an average to 18 to 24 hours some certain times, and this required natural intervention of technology in terms of addressing this issue. So fundamentally, if you look at the problem statements, these are repetitive same issues where fundamental need was, can we automate some part of it, understanding what needs are there. Then also, the idea was that it's not just about you fix the issue of collecting the information, but is it being used at the right time and right place, and also not just at one place but across the journey as well, which in the context of pregnancy, it's really useful if I have information of antenatal period during the labor and birthing timing. So that journey connection or workflow integration was another important learning. And then the last and important piece was also that now we are generating data. Can we identify opportunities to predict or flag certain type of risk which can help in early intervention? So the workflow integration came by looking into where technology can be placed and information can be collected. Just to give you a context that the way we collect the information for fetal and labor monitoring feeds the information to identify or the rightmost part where we are color coding, giving the auto interpretation for the CTG graph, where for an individual doctor it would take around 5 to 7 minutes to interpret it systematically and still limits to 2 to 3 parameters. Now we are able to give around 7 to 8 parameters which are of higher clinical importance with accepted sensitivity and specificity, and more importantly because it is digital nature compared to a thermal printing based graph which conventionally doctors would read. The ours ones are now naturally 40% better in terms of interpretation as well. So this understandings ultimately came one as a classic problem statement which I described. But how a user who is fundamentally a nurse or midwife, who not necessarily trained compared to the midwives in Western world where midwives are trained to interpret CTGs, versus a nurse or ANM at the PHC level who is just looking at this graph, understand what she should do. So we brought some color coding based upon certain type of risk, and those color codings basically, let's say a red line on the graph indicates that she should seek advice from the higher, either expert from the higher facility or connect remotely also. So these kind of interventions were brought in based upon the need and utility understanding, and not necessarily because I have an algorithm ready which works best and I'm good to go. So these are some learnings that we got, and will not go into the details of every data set or information sets we have, but fundamentally the last mile care approach and risk stratification approach increased the early registration of pregnant women in the first trimester. That was the access problem solving, but the risk stratification helped us to focus on mothers who were having particular type of risk, and data from Palghar, where malnutrition is the bigger issue, we could literally pinpoint mothers in the high risk, and around 2.1% low birth rate incidence reduced in 3 years of time by systematically targeting the population. And the block which was performing as the second last but win in the performance became the top 2 performer, not just by one factor, but technology helps you, or risk stratification help to pinpoint mothers and address their challenges. So that way triaging and information utilization was utilized to intervene as well. And I think that was one of the biggest learning for us as well. In terms of fetal and labor monitoring, naturally there are fetal distress or birth asphyxia related indications, or even in labor monitoring some of the new digital biomarkers we are working on, but we could spot around 100 cases of acidemia which otherwise manually would have been totally missed, and it's not also possible to manually detect them. So the solutions were evaluated in a different forms and context, both in India as well as but in global context in Nigeria, in Afghanistan, and published with various partners. But these things brought in very interesting learnings. The reason I brought is that replicating brings its own challenges. The technology or the science remains the same, but the local context were brought in, and some of the fields or information points which we were collecting in India were of no use. So the attributes or the number of fields or features that we want to evaluate your AI models will also change, and they may be of higher value in the local context. So repurposing your models to those data sets, it's again an additional exercise, and sometimes it's not just AI model but a lot of basic data points which we do not consider, and local language translation, cultural aspect for certain visuals that we give. So all those learnings came in out of this evaluations. So in summary, currently around 6,000 to 7,000 fetal monitoring tests are being done weekly basis using our devices all across India, piloted in some of the neighboring countries as well. And there are definitive learnings while implementing the solutions in private health settings versus in public health settings. So just this is our wish to naturally use AI and marry the data with AI, but simply it's not that straightforward. And some of the I thought better, I will also use bit of AI to generate some slides. So did that in the morning. So basically, when we are talking about implementing, these are some of the learnings also, which are mostly talked about by earlier speaker. I'll just bring one point which I think was very useful for us, was the post-deployment learning as well. And it is figuratively not possible everywhere you can able to get the data in the post-deployment because of either accessibility, even the permissions, which you get from particular governments or partners to collect the data. But at least what we did, we wherever possible requested our partners to help us to get the post-deployment data, or let's take an example of pregnancy, a complete continuum of care data right from antenatal level to the newborn monitoring level. And that learning brought us quite important value in terms of retraining our AI models. And the biggest advantage which came up across the exercise was the 3 layers of data sets that we are able to collect, right from the antenatal level to the postnatal or newborn monitoring, and that becomes an important engine now to even evaluate our own or new digital biomarkers quite faster way, and that's what built various strategic partnerships for us. So this was a different way of learning, that by having systematic approach of collecting data, partnerships can bring opportunities to apply your data sets for different hypothesis testing as well. We are doing some interesting work with University of Oxford, funded by Wellcome Trust, on analyzing the effect of extreme heat on pregnancy, and again testing the machine learning models, how fetal monitoring or the fetal distress is affected because of heat. So those kind of elements are also possible, and then because the data was collected on a real scenarios, the evaluation or the validation of the machine learning models also become easier comparative to every time going back to the field and doing the same thing again. So naturally the another piece was aligning whatever work we are doing with the national and global health policies or national programs. In Indian context, aligning your solution with the government programs becomes extremely important for adoption. So just addressing that point, of course, almost everyone spoke about the compliance and certification and evidence. But yeah, primarily summarizing that, embedding into the workflow, getting aligned with the national programs, generating data which can be then used for multiple approaches, not just one problem statement specific thing, but looking the solution or the problem in a holistic manner, and ultimately generating evidence for the government for that one thing, and then becoming partner with them to addressing various challenges. It's what the dynamic model that as a AI strategy you say, or a data strategy that we use, and keep building new solutions as well. I'll pause here. Thank you very much.
Thank you, Dr. Shantanu. Now may I request Dr. Karthik Adapa to kindly come on the stage to felicitate the speakers. I call upon all the speakers of this session to come on the stage. Dr. Geetha, Dr. Anand, Ms. Veena, Dr. Shantanu.